Thank you very much, ladies and gentlemen. Thank you very much, BSET, to have me with you again. I've been missing the game of cricket, although it wasn't really cricket, but it looked like cricket in the gardens in Gloucestershire. And hopefully we can have that soon again. I'm happy to jump in now for Gustavo with a case on a patient with a thoracal and or abdominal aortic aneurysm. I will click myself, see if this works. It's technically well done. So there's no relevant disclosures for this case. This patient was referred to us via cardiology for an incidental finding of an enlarged descending aorta on an ultrasound that was made for chest pain. He's a male patient, 75 years old. He's asymptomatic at that time. He's suffering from diabetes, hypertension, claudication of his left leg, and he smokes cigars since he was 15, a good old Dutch habit. He was reasonably fit, had a good pulses on the right, absent pulses on the left, and relatively normal lab tests. His axial CT scan is like this, and we'll discuss this in detail later, but you can appreciate already a dilation there, another dilation. The visceral segment is not normal, and then there is here an occlusion of the left iliac axis. So some extra imaging here, two different views. I'll run this twice and then run the coronal. So the ascending and arch is actually normal. And the largest dilations are in the chest and in the abdomen. And these are the measurements just taken on axials. So the largest dilation is 73 millimeters in the chest and 53 millimeters in the abdomen, leading to conclusions on this CT that the ascending arch is normal, the proximal descending aorta is 34 millimeters, there's a mid-descending dilation as shown, the distal descending aorta and the visceral segment is not normal but back to 35 millimeters. There's a celiac stenosis, we call this a celiac band. There's an SMA left renal and right renal that are patent and normal size-wise. The abdominal aorta measures 52, 53, right common iliac 14, the right internal iliac is patent and the left iliac axis is occluded. So you could call this a type 2 thoracal abdominal aortic aneurysm. And the discussion points for a case like this would be, are we going to repair this open and endo, or let's say first the patient is fit enough to have a repair and there is an indication size-wise. So open or endo, is this something to stage? What about the axis and the occluded iliac axis, and how to prevent spinal cord ischemia? I'm open to have a short discussion with the panel on these points, or I'll just continue until what our strategy was. Maybe Paul can help me here. Or shall I just continue?
Why don't you carry on and just run through your thought processes that that went with what your decision making, and then we can have a think about them.
Great. So we choose endo repair. We thought that staging would be beneficial, and since the descending, distal descending was suitable to treat with the TEVAR only, we choose this option. We choose to go percutaneous and unilateral, and at that stage we still did CSF drainage and then a couple of days in ICU with a mean arterial pressure above 85. So we double punctured the right groin, pre-closed one puncture and put in a 9 French sheath and then a 5 French sheath additionally to have an access for a pigtail for an angiogram. And this is, I think, relatively straightforward because there's a nice proximal neck. First device that was put in was a 4036 tube graft, ZTA. This is the angiogram to look at the distal sealing zone, trying to go right up where that curvature is with a P 40/40/167. And this is the end result of that TEVAR procedure, which was, I think, adequate. So, closed the groin punctures with 2 proglides and an additional angioseal and an angioseal for the 5 French hole. He did well in ICU for 3 days. We keep the hemoglobin over 6. We stop the inotropics first, and then take the spinal cord drain out. And actually, this went uncomplicated, and he got home at day 4. At 1 year follow-up, he suffered a bit from back pain since the TEVAR. We suspected this due to, or he suspected this due, and maybe us as well, due to the CSF drain, but was otherwise well with the laboratory values you can appreciate. And his CT scan is like this, demonstrating actually a good position of the thoracic endograft. No changes in the visceral segment. However, difficult to see, but there is further dilation of the abdominal part. And actually on the left you can appreciate that the thoracic aneurysm has shrunk. So, a correct position, no endoleaks, shrinkage in the chest, growth in the abdomen, no further changes and no changes in axis. Again, we've now made this a type 3 thoracoabdominal. Discussion points again will be open and endo. This will be easy because we embarked on endo before, but there are patients that benefit from an endo approach in the chest and then an open approach in the abdomen. If endovascular, what kind of configuration and what to do with the axis, and is there now, is the occluded iliac axis a risk factor for both axis as for spinal cord ischemia, for example? We choose endo. The patient was suitable for a T-branch. We choose an AUI device to go more distally. We did a redo percutaneous right common femoral artery approach, redo between bars because it's a redo after perc, of course, and put in another CSF drain, MEPS, and kept the blood pressure high. So if we do redo axis, we take a different approach. This is redo axis for surgical grafts in the groin or for patches in the groin. We use micropuncture sets or a 4 French dilator. We use a short amplet, 75 centimeters wire, and then use the same pre-close technique with progressive dilation if needed. In this case, we put in a 9 French sheath and we put in 2 guide wires parallel to avoid a second puncture. This is the angiogram to define our landing zone, because the first graft that we put in was actually a 40/32 tapered thoracic stent graft. We keep the ACT over 250 in these procedures. The second graft to put in is the T-branch, which is lined up there. After the T-branch, we removed the pigtail and then got rid of that extra guide wire, which ran then of course beside the big sheath. We put in an AUI device, but we removed on the bench the top bare stent because we don't like to perforate the T-branch with the bars and the hooks of the bare stent of the AUI device. And then extended with the ZSLE 1690 leg. And the distal landing zone from the iliac is okay. We downsize our sheaths and then insert a modified 10 French steerable sheath. And this is an image of a small technical paper that we published that shows you a steerable sheath and demonstrates what happens if you put in a steerable sheath an additional sheath or a catheter or a covered stent. Then the angle or the diameter of the curve will actually decrease. Therefore, we use a little trick, which is a suture that we suture through the distal bit of the steerable sheath, which runs through, in this case, a 16 French sheath. And by pulling the suture while maneuvering, you can keep a very nice 360-degree curve, which is very stable and will accommodate every covered stent. So with this technique, we started off with a celiac trunk, which we normally would do last for the MEP test and to leave open. But because of the stenosis, we did that first. And we saw actually that it was occluded. So you can see that there is an occlusion of the celiac. We didn't recanalize that. Discussion point for later, maybe. We then went to the SMA. This is the completion angiogram of the SMA, the right renal artery, and the left renal artery, which we both extended with self-expanding stents. Then we do a MEP test. I mean, it's probably too long to explain everything about this, but using motor evoked potentials, we test with 15-minute occlusion of the celiac trunk whether the spinal cord function stays okay, which it did in this case. And then we put in a covered stent, although not deployed at the distal bit, and then put into Amplatz plugs. So we put in a longer covered stent than just the branch, because otherwise the branch won't thrombose so fast. You will appreciate that the 4 dots of the Amplatz plugs inside the branch. Okay, completion angiogram is nice for the target vessels. There is some endoleak around the visceral segment, which we think is due to the non-thrombosis of the Amplatz plugs, and there is in our opinion, was a type 2 endoleak at the back of lumbar at the bifurcation of the aorta. He did well. Again, 3 days in ICU. We had a malfunction of the CSF drain, so it was out after day 1. He didn't have any leg ischemia and didn't have any spinal cord ischemia. He was home at day 4. This is his follow-up scan, and he's not very long in follow-up. Thoracic bit is fine. Occlusion of the celiac branch. The branches are fine. You may have seen a little endoleak, and there's another one. And here are the 2 endoleaks, visceral and aortic bifurcation, both coming from segmental arteries. And for the fast watchers, there was a dissection in the right iliac axis, which was non-flow limiting. So in the end, we think we had a good result, but short-term follow-up only. And I brought this case because of several discussion points, things that we could discuss on staging, whether or not to do CSF drainage, especially twice in a patient who may have suffered from back pain. What about the MEP test? Is it useful when you do have an endoleak like we did? What to do with an occluded celiac axis, and when it happens, what do you do with a branch? And then the axis strategy in case you have a uni-iliac axis, and are these patients at risk for spinal cord ischemia or leg ischemia? I'd like to thank you for your attention and give the floor back to the panel.
Barend, thanks very much. I think we're just going to go ahead and go straight on with Gustavo's case, if that's okay, and then we'll come back at the end of the cases for some questions.
So, Chris, I think Gustavo has been called away, so I think we'll just carry on with questions, with a few questions for Barend's talk.
Fine.
And really want to encourage the audience to get involved and send questions in.
So Barend, as someone who doesn't routinely use CSF drainage, do you find it a useful thing? I mean, I've taken a sort of selective approach if patients get symptoms with really careful monitoring.
We have been routine users over the last 10 years. For open thoracoabdominals, we are still routine users. For endo, we have moved away a bit like you to go to selective, and also like Gustavo, who's of course well known for his paper and his opinion on this. And the reasons for that were the literature and your experience, but also we've seen quite some complications. Most thankfully not so severe, but they are like malfunctioning. So they're taken out, they're put in before surgery, and in the evening in ICU already they malfunction. We've taken there's a discrepancy at the moment with the tools we use. The size of the drain needs to fit the automatic pressure and measuring machine, and if it doesn't connect well, then there's a function problem. We've had patients that had a bloody tap when they had or bleeding when they had it placed, so the whole procedure was cancelled. And we've had patients with a hematoma causing a temporary tear or mostly unilateral spinal cord ischemia. So we are taking an approach to type 2s we would regularly still do, and type 3 and 4 we would only do if they have complaints.
Barend, 2 questions from the audience, just so we can make everyone included. Did you have concerns about covering some of the collateral flow to the occluded leg with the stent graft?
Yes, we've done now a few, I think 5 patients with a unilateral iliac occlusion and a complex aneurysm, so either fenestrated or branched. We've looked with Gustavo, we've looked at our combined experience and are ready to submit a paper on it. And we are always worried about leg ischemia, which we find out mostly at the end of the procedure. And in the time that we've done it, and also in his series, I think there was out of 15, there's been 1 patient that needed an intervention at the end of the procedure, like a fem crossover graft. But you never know what's going to happen.
Okay, so 2 quick answers, please, Barend. There's a couple of questions on spinal perfusion. So one is about near-infrared spectroscopy, so using these pads to monitor blood flow in the paraspinous circulation as a surrogate for spinal perfusion. What's your experience of NERS? And then the other question is, do you use MEPs to decide on your drainage strategy, or whether that's pre-decided before you do any motor evoked potential monitoring? So NERS
first. Oh, okay.
Or
NERS,
whatever.
Yes. NERS, yes, experience in a trial that we do where we look at all the patients without any clinical decision making, just to learn. So we don't do this for decision making, but we put the pads on every patient with open or endo to learn from. And I can't share yet all the results on that. Second question, no. MEPs are only being used for deciding whether we can finish the procedure at once by attaching the last branch, and not for our CSF training strategy.
Okay, one more, I think, because I don't think we're going to get Gustavo back. He's been called to an emergency. So in case of a type 1B endoleak at the time of TEVAR, what technical therapeutic strategies would you consider? So what is your algorithm for dealing with type 1B endoleaks?
Well, so first of all, I think the sizing is not okay, or the positioning if you have a type 1B in a TEVAR, because it's a tube. So, but things may happen. Then if it's placed too high, an extension is a possibility. You can do aptus, which we have not done. I think I would go over the celiac trunk, but first make sure balloon in the celiac trunk, angiogram SMA. Is there filling of the celiac trunk? If yes, we cover. If not, we use a snorkel. I think that those would be my intraoperative. So first of all, an extra balloon is the first step probably.
Okay. Thank you very much. Chris and Paul, take it away for the next, I think. Those are all the audience questions.
Excellent. So we're going to move on to some lower limb side of things, which is definitely Chris's area of expertise over mine. But we have the pleasure of welcoming Paul Moxey, who's a consultant vascular surgeon at St George's and a BSET council member, with a case. Paul, welcome.
Thanks, guys. Thank you for the invite to present a case. I have to say mine is not as complicated as the previous case. You'll be pleased to hear. I can't see. There we go. Some slides. Excellent. Okay, let's see if this clicker works. So the reason I chose this case partly is that we only did it 2 weeks ago, so it's fresh in the mind. But I think it represents more the decision making that we're presented with, both sort of before the case, but also during a case. So this is an 85-year-old lady that I'd seen in the diabetic foot clinic. She'd had kissing iliac stents earlier on in the year. She had the bilateral SFA occlusions at the time. So, you know, there's always this argument, isn't there? Should you create straight line flow or not? In this case, the decision was made to just treat the iliacs initially, but that wasn't successful in treating the rest pain. And then she actually developed tissue loss in the left foot. So the problem was that she's got an EGFR of only 29, but she was otherwise, you know, relatively independent, completely with it. So the options that we're presented with obviously is a choice between open or endo. She probably could have got through a general anaesthetic, but the renal failure was concerning in terms of whether she should have an open repair or not. It's obviously also concerning as to whether she would support an endo repair. The kissing iliac stents cause an issue in terms of access. So in terms of access options for endo, we could try coming up and over the top and be cautious of those iliac stents. We discussed coming retrograde from that posterior tibia and doing a safari type technique. The concern with that is where are you going to snare if you are able to come retrograde and get through that left-sided occlusion from below. You're obviously going to need to snare your wire, probably in the common femoral, and you're still going to need to come up and over really, or come down from the arm, which we've done a few cases of, but coming from the arm you need very long wires and catheters, and we don't have that equipment. We've got a lot of equipment on our shelves, which we're very lucky, but we don't have necessarily stuff to come from the arm. So we decided that we looked at an open repair, at a bypass, sorry, and but that, in a way, we were fortunate in that the vein just really wasn't good enough. So the leg veins were small, and the arm veins even smaller. So, you know, I think an open repair, a bypass, was out of the option. So we were pushed down the endo route. Let's see if I can get these angios to play. Excellent. Okay. So my plan at the start was to come initially to try coming up and over from the right-hand side, an ultrasound guided retrograde puncture of the right common femoral, come up and over and park a 6 French destination in the external iliac, which was a bit of a fiddle, and we're obviously concerned about those iliac stents, but they didn't seem to budge, which was good. And so we obtained these angio runs, and the difficulty here was where is the origin of the SFA. It was possible just to see a little nubbin, and you can see it just in that middle set of images there. where the wire has just begun to curl in the origin. But that was probably one of the trickier bits, was getting access, and it meant tipping the C arm from side to side and just trying to get that perfect angle. So we got into the origin of the SFA, and that image on the right hand side of your screen is the target, which is the above knee popliteal. You can just see it filling just about there. So it's patent. So unfortunately, I don't have the fluoro loops of the actual recanalization, but I mean it wasn't a particularly tricky. Once we got into that origin of the SFA, using initially a combination of a straight Terumo that had coiled and a DAV catheter, mainly because that's the longest sort of standard catheter we've got, and then changing to a V18 and an 018 CXI, we were able to come down the full length of the SFA relatively straightforwardly. Then and a colleague who shall remain nameless managed to pull the wire out. So there's and it's one of these things, isn't it? You've put all your effort into the difficult bit, and then you make a silly simple mistake, and that was unfortunately while we were doing a catheter exchange. So we lost wire access completely, and probably lost half an hour because we had to go back and actually getting back into the origin of the SFA again was a right faff. But once we got in, the wire went straight back down, and breaking back into the above knee popliteal wasn't particularly difficult. We didn't need to use re-entry devices or anything, which is good because I'm not sure we've got a long enough outback, even if we needed to. The problem was, as you can see on that angio image on the right hand side of the screen, that around the BK pop, sorry, the above knee popliteal is diseased. So there's calcification and stenosis. So my thoughts at this stage are, it doesn't appear to be flow limiting. Do we leave it? But we've got a long subintimal tract that's a high risk of reoccluding. We decided to treat it. And you can see on the right hand side there, that still image of the Stellarex balloon, how that calcified chunk is deforming the balloon, pushing off to one side. But it was a prolonged 3-minute Stellarex drug-coated balloon dilatation. But then, unfortunately, you can see that there's a localized dissection, which again doesn't seem to be flow limiting, but there's still a stenosis. And at that stage, we're probably, we're wondering again, do we intervene? Do we not intervene? Is better, as the old phrase goes, is better the enemy of good, and should we just leave that? I didn't feel again that we could leave that. There's actually a number of different views where with the C arm in different planes, where actually that stenosis was more significant than it looks there. I think, as we all know, there isn't a stent that's really on IFU for treating that area. Contrary to everyone's belief, the Superior is really only licensed for the SFA and P1, but we're heading well into P2 here. So I think in hindsight, this may have been a case to then move to an atherectomy device. Having said that, of course, we're at the beginning of our journey of atherectomy. It's something that we've now done a handful of cases of, and we're learning. And I think we need to have those cases pre-planned. We're not at a stage, unfortunately, in our practice yet where we can just reach for the atherectomy device mid-case. So we decided to go with a Superior stent, which are never my favourite devices in terms of deployment, but I think it improved things. If I'm honest, I wasn't that happy at the once it had been deployed, but I think it looks better, and there's certainly no flow limiting to what's going on. The problem, though, as you can see, is what our wire has done to the TP trunk and the origin of the posterior tibial. And you can see that on the image that's still playing on the other side of the screen. So again, we're in this situation, aren't we, where we're already 2 hours into the case. We've got a single vessel runoff. We've just demonstrated again that while you're doing something upstream, you could be causing some damage downstream. This was all done over a V18 up to this point, so you wouldn't normally expect there to be. So whether that's a bit of thrombus, a bit of debris that's come off, or whether that's some actual wire damage to the intima, I wasn't sure. But again, I felt that we needed to treat that, so we gave it a gentle dilatation with a 3mm balloon. And this is the sort of final completion run. Still not 100% happy with what's going on in the popliteal, but it looked a lot better. And then you can see it's actually that I breathed a sigh of relief when we got that middle image, because we've got a single vessel runoff and a 3mm balloon angioplasty to the TP trunk and origin of the PT. And we gave, I think, 100 micrograms of GTN as well, just to try and stop any spasm. And then you can see it actually fills the foot arch really rather nicely. So we were pretty pleased with that. And so this is the duplex image that was taken a few days later. Again, just in terms of our normal practice, we don't normally run heparin infusions, but to make me sleep better that night, we ran a heparin infusion. And the patient was initiated on dual antiplatelets. I actually saw her this morning on the ward, and we amputated the hallux and second toe, and that wound is healing nicely. So it's been a good result. I think the key points for me are: you can have a plan, but you need to have another plan in reserve. You need to have a plan B and a plan C. You need to watch your wires like a hawk, and whether that's with your colleagues, and your hard-earned gains can be lost very quickly by sort of taking your eye off the ball. And both watch your wires in terms of pulling your wire out, but also watch where the tip of your wire is, and watch what's happening. And that damage that we saw in the TP trunk was likely to have been wire damage. Calcified popliteal lesions. I think we got away with it here with the superior, and I think it looks on the duplex there as if it's remodeled. But if you've got atherectomy at your disposal, I think once you're up your learning curve, and particularly getting it all set up and getting it ready, I think maybe I would have preferred to have used that than a stent in that region. But I think we're learning, aren't we, how this technology all fits together. And as I've already said, watch for distal damage, and I think treat as needed. And I don't tend to keep trying to gild the lily. I tend to settle with what we've got. I often worry that we're going to cause more harm trying to make things better. But I think in this case, each step was necessary. So that's my case, and I'm very happy to take some questions or criticisms, or why on earth did you do that, Moxey?
Thanks, Paul. I wonder actually if we just go on to Murray and then throw the questions at both of you at the end, if that's
Absolutely.
Okay.
Sure.
So can we go over to Murray Flett now for his case? Murray's a vascular surgeon up in Scotland, in Dundee, and he's very kindly come along to go through a lower limb case with us too.
The case I'd like to present is another lower limb case. A chap who presented to us back in 2013, 2014, 58-year-old male, still working at that time, disabling right thigh and calf claudication. respiratory disease, ex-smoker, and a year or so back he'd had radical surgery for bladder cancer, radical cystectomy, pelvic lymph node dissection, and he's got a stoma in his right iliac fossa. So at that time he had an MR angiogram, which you can see here, hopefully, showing a right common iliac occlusion, reconstitution just proximal to the iliac bifurcation, and pretty good runoff distal to that. So this chap was treated with kissing balloon expandable bare metal stents at the aortic bifurcation. Was thought to have had a good technical result from that. However, it was unrecognized that the stents were actually malpositioned, and hopefully you can see that the left iliac stent is actually completely overriding the right common iliac stent. I've just outlined the radiopaque markers at the top of both stents, so hopefully you can see that. And that was not recognized at the time. So he was seen again a year later, 2015. His right iliac stent had occluded on duplex. He had recurrent disabling claudication. I think by this time he'd retired, so he wasn't keen on further intervention. He was managed conservatively. Some 5 years later, just at the tail end of last year, he was re-referred to us with deteriorating symptoms over several years, rest pain, sleep disturbance, but no tissue loss. And this is his CT angio. Hopefully I can just run through the axials. And this now shows that he's got full-length occlusion of his right iliac system right down to the origin of the common femoral artery. No significant disease in the common femoral. It reconstitutes just at its origin, just distal to the inguinal ligament at the level of some enlarged collaterals, including this, which is this, I think, is the superficial deep external pudendal, or sorry, superficial external pudendal. So the treatment options, he has a task D or a glass stage 2A full-length right iliac occlusion, right down to the origin of the common femoral artery. He could have redo percutaneous intervention, hybrid approach with open exposure of the common femoral artery, or he could have open surgery. We chose a hybrid approach. Infrainguinal exposure of the common femoral artery, but control of the external iliac above the inguinal ligament and proximal to the circumflex iliac collaterals. And then percutaneous retrograde puncture of the common femoral artery before it's opened, and transluminal recanalization of the iliac occlusion. And then with a guide wire in situ, we open the artery, endarterectomize the distal external iliac and the proximal common femoral, and then patch from above the ligament and above the circumflex vessels down into the common femoral. My clicker has stopped working. Here we go. So percutaneous retrograde access on the left side, a guide wire up into the aorta. And as I said, prior to performing the endarterectomy and patch, we recanalized the right iliac occlusion. That was tricky with the guide wire recurrently going in extraluminal to the occluded stent. And even after an apparent transluminal guide wire, we still couldn't or had a great deal of difficulty tracking a sheath up through the occluded stent. So we used Dyna-CT or cone beam CT to try and help us verify that we were intraluminal within that occluded stent. And with the axial CT, you can see that it confirmed guide wire within the lumen of the stent. So angiogram prior to stenting the lesion. This is carried out after endarterectomy and patching on the right side. Simultaneous pump injection via pigtail catheter on the left, and a hand injection into the right common femoral sheath just to delineate the proximal and distal landing zones for the stent graft. And then using covered stents, building from below with in the external iliac an 8mm, 10 centimeter long self-expanding Viaban stent graft in the external iliac, and then proximal to that overlapping balloon expandable VBX stent grafts. And a completion angiogram that shows a good runoff on the right side down into the patched common femoral artery, distal external proximal common femoral, with preservation of these collaterals at inguinal ligament level. So points I thought were worthy of discussion in this case is that the approach to revascularization in this patient with previously failed first endovascular procedure, also task D full-length iliac occlusion. We chose a hybrid approach, but that possibly may be controversial. Partly related to the fact he had a stoma in his right iliac fossa and previously extensive pelvic surgery. So current guidelines, the global vascular guideline on chronic limb-threatening ischemia and the European PAD guidelines both suggest that a hybrid approach is recommended for inflow disease extending into the common femoral artery. But low level of evidence, predominantly single center retrospective studies, but I think this does represent widespread clinical practice. But what about task D, extensive lesions involving the full-length occlusion of the iliac right down to the origin of the common femoral? Both these guidelines suggest that open surgery should be considered in fit patients. Again, low level of evidence to support that recommendation. However, I must admit, we don't think that percutaneous approach to treating this disease is appropriate, even when the common femoral artery isn't significantly diseased. Percutaneous treatment requires stenting across the inguinal ligament into the common femoral disease, or into the common femoral arteries. And if you don't, then you will have untreated disease distal to your stent. I think there is some evidence of an increased neointimal hyperplasia response if you stent across the inguinal ligament, and you also potentially exclude these important collaterals just at and below the level of the inguinal ligament. We've certainly seen patients treated percutaneously who've had failed stents presenting with profound degrees of ischemia as a result of that in the past. So we have, as I said, we've had previous poor results when we started treating these long task C and D lesions, predominantly related to distal disease as the cause of failure, we think. So we have a very low threshold for open exposure of the femoral artery, extending above the inguinal ligament, but not dividing the ligament, but patching up into the distal external iliac and then stenting low down into that patched endarterectomized artery, and trying not to stent across the ligament or cover these circumflex iliacs or the external pudendal arteries. So I think that's all I have to say on that case, but just welcome any questions on whether people disagree.
Murray and Paul, both.
Thank you very much. Murray and Paul, thank you both for that. Just coming up from our other presenter from Barend, who was just asking a question for you, Murray, was what do you think about CRAB in that case?
So we generally don't do a CRAB type of procedure unless there's significant disease within the aorta or at the aortic bifurcation. So I don't really know if CRAB would have anything to add in this case, other than realigning a distal aorta that isn't really diseased in any way. I mean, there may be some theoretical hemodynamic advantages, I don't know, but we generally don't do a CRAB unless there is significant disease in the aorta itself.
Thanks. Can I just ask something quickly before maybe we go to the audience questions? Paul, you've obviously done a long SFA recanalization there. What are your beliefs around surveillance for that afterwards?
Yeah, we treat them similar to it's essentially an internal bypass, isn't it? So we treat them like we would treat a bypass, and so she'll have a duplex at 6 weeks, and then 6 weeks, and then 3 months, and 6 months, and then we sort of go out to 6 monthly and hope it lasts that long. But yes, we have a well-established graft surveillance program, and for these types of cases, we treat them like a bypass graft.
Okay, thanks. Bijan, have we got any audience questions?
Murray, there's a question for you. Would you do, or do you do, remote atherectomy? Did you hear that?
We don't have any. Yeah, I did. Yeah. We haven't done any. Done some femoral popliteal atherectomies, but not in the ILX. No, got no experience of that actually.
And then there's another question from the audience asking, what do you think happened at the initial operation, Murray? Because it looked good on the balloon deployment.
That's hard to say, because the only thing that's recorded on PACS were just static images rather than any sort of fluoro runs that were saved of the deployment. But it must have moved up or down at some point during deployment. The top of the right side of the stent actually looked like it was kinked somewhat. So hard to say what caused that.
And then I have one final question for Paul. You said you started IV heparin to make you feel better. What's your approach to anticoagulation in these cases? Because sometimes I think if you start IV heparin, then you don't always achieve a therapeutic dose. How do you choose between IV heparin, low molecular weight heparin? What is your strategy usually for a sort of dodgy result?
Yeah, it's a pretty evidence-free zone, isn't it, Bijan? And I think a lot of the heparin infusion is therapeutic to the operating surgeon rather than the patient. And I think the dual antiplatelets are paramount. I think when it comes to full anticoagulation, you're really sort of hoping that you're treating any sort of immediate chance of thrombus forming in that long subintimal tract. Yeah, I agree. We very much don't keep heparin infusions running long term. We would very overnight really maximum, and then we're very much a treatment dose, low molecular weight unit when it comes to that sort of thing. So we don't do it very often. We have a protocol. We have and the nurses on our PACU and HDUs are used to trying to keep the patient within the therapeutic range. But we all know that patients spend a long period of time either too high or too low. So it was switched off the next morning, and the patient was just left on dual antiplatelets. It's one of these questions. The whole gambit of heparin, dual antiplatelets, low dose rivaroxaban, etc., and where it fits in with our patients is obviously Chris's bag, and there's some work coming up hopefully that's going to answer all of those questions for us, hopefully. But a lot of it is done just on your sort of experience and your feeling of what you feel that patient needs at the end of the case. Unfortunately, it is as simple as that.
Okay, there's another audience question, specifically pertaining to the Supera stent. How good do we think is the evidence behind some of the claims made about the Supera stent and how it distinguishes itself from other strategies? Maybe Murray can take that one, or Paul.
Well, the only evidence I'm aware of is the company-sponsored trial that Abbott did. I forget what I think it was called, the Superior trial, or something similar. And like most of these trials, I think it claimed better results than conventional nitinol stents. It's very difficult to know. I can't remember the proportion of patients who had limb-threatening ischemia in that trial, but I don't think it was very high. And it's all a lot of these different trials looking at different treatment modalities in the femoral popliteal segment. They all show these predominantly industry-sponsored trials all show better results for whatever device they're studying. It's very difficult to know what device you should use, whether it's drug-eluting technology or conventional nitinol stents or superior stents. So I don't really know. And I think what I would say is the superior is quite tricky to deploy. What with having to pre-dilate the vessel to a certain diameter, it does not work well unless it reaches its nominal diameter. So I think it is user dependent, and there's a learning curve with it. So I think
I would absolutely. Yeah, I mean, I'd absolutely agree with that, Murray, and particularly around the learning curve. And I'm going to put my hands up and say we as a trainee, I saw some disasters with superiors, some in my hand, but getting the packing all wrong, and not deploying them being sort of deployed if you're doing them retrograde and into a sheath, and then you take the sheath out at the end, and the superior appears on the end of it, and it's it is tricky to. There is definitely a learning curve to it, and it's not something that you should try. For the first time in those circumstances. I think if you need to put a stent in and you've not done a superior before, then something you're much more comfortable with would be better.
Great. So thank you very much, Paul and Murray. Chris and Paul, I caught the fact that I think Gustavo is back, so we are running behind, but I don't think we can pass up the chance to see one of Gustavo's cases. Can we just check with the AV folk whether Gustavo is back and he can join?
Can you guys hear me?
We can.
Yeah. Okay, I'm gonna share my slides here. Can you see my slides? Okay, very good, guys. Sorry for the lack of proficiency here in the system, but I have a case to share with you. It's a renal artery fenestration misalignment. Briefly to talk about the patient, this is a 65-year-old male. He is very conscious about his body. He is actually physically very fit. He underwent a previous endovascular repair using an Endologics device in one of the Houston institutions, actually. And he was referred to me when I was at the Mayo Clinic. And then he followed me. And he basically had a multifocal thoracoabdominal aneurysm, as you'll see, with an intervening segment of relatively normal diameter aorta. Now, the proximal aorta was 4.8, and I discussed with him two approaches first, and that I think is a topic for discussion. First, I said, well, we can stage starting with the thoracic and then we complete, or we can focus in the bottom part, which is large, and then plan that the top at some point will grow to about 6, and then we fix the top. He was overly concerned about paraplegia, and right or wrong, we decided to focus in the bottom first. So that is the first topic. Second, I want to point out to some of my measurements here, and the inner aortic diameter was about 36, which is fairly large at the renal arteries. Remember this number. And the renal arteries were tough ones. They were very posterior. They were tortuous. They had a posterior orientation and a little bit upgoing. So I was concerned about the use of branches for the renal arteries. Now, in retrospect, maybe that was a mistake, but this is the design that I opted for. 2 downgoing branches for celiac and SMA, 2 fenestrations. He's also a very tall man. Note that this is a long device, and I elected to elongate this device distally into that endologics, and we could put there a tapered component and then a bifurcated. So again, the procedure was done with this custom device, 2 fenestrations, 2 branches, bilateral percutaneous femoral approach, right brachial axis. And we used the VBX stents for the celiac and the SMA. We had no difficulty with that. And we had no difficulty to do the right renal. And actually, I had cannulated the left renal, but unfortunately, the device rotated, and with the tortuosity, we could not advance a sheath. We ended up losing wire access, and I could not catheterize the left renal artery. I played with the catheter for a while, but after about an hour of trying, I quit, and I decided to just quit. He was doing fine, and I decided to fight the battle another day. Now, this is a CT with limited contrast, and it shows here, unfortunately, it doesn't depict exactly where the fenestration is, but the fenestration is around here, so it is misoriented, and we have this space, and we have to connect this fenestration to that renal artery. I'm happy to answer questions at this point if you have. I don't know if anyone wants to ask a question. If not, I'll carry on. So this is the second attempt. So first, I went from the groin. We can see I have a 12 French sheath and then an 8 French steerable sheath. I accessed the space between the two. I tried to get the wire in, but it didn't go. Now I looped the catheter around, and actually, surprisingly, the glide wire just went in. And I knew it was going to be very difficult to straighten that, so I started building a coaxial system. So now I have 6 French sheath and a 4 French sheath coaxial inside the 8 French sheath. So now I have a 4 French tibial sheath with a 6 and then an 8. And now I'm going to try to straighten this system. Now, this part happened fairly expeditiously. We're not working for a long time so far. And I tried, but unfortunately, even with a balloon holding that sheath there, I could not get the system to straighten. And it became very evident it was going to be very difficult from below. So at this point, I now get access from the right arm again, and I establish a through and through axis with a 0.14 wire and have a 12 French sheath. Now, the first thing I want to say, this is not the first. Can you guys hear me? Okay. So the first thing I want to say, this is not a 45, this is a 65 French sheath, okay? Note that I'm not being able to catheterize from above. It was very difficult to orient catheters because of the tortuosity. So what I did is I catheterized from below, and then I did a snare ride. Look at that, I am snaring the wire to bring the sheath to the fenestration. So now I lock the sheath there from above using a snare ride technique that Marcelo Ferreira described. And then once I locked, finally, I was able to get a catheter in and eventually direct a wire. And you can see it was very difficult, lots of manipulations. I discussed with the patient before the possibility of a flank incision and retrograde approach, so that was the backup plan. You can see here the difficulty, and the snare ride is really helping keep that sheath close to the fenestration. And eventually, we were able to get that 6-French sheath inside the fenestration. And then using a catheter, you can see the misalignment eventually get the wire to go where we want it. And I don't like a loop in the wire. Unfortunately, that's what we got. I think that can cause dissection. And eventually we got a catheter. Now I have a more stable system. I don't like Amplatzer wires, but on a case like this, unfortunately, we need it. This is unfortunately also a relatively short length stent, but remember in the United States, we only have the ICAST, which is up to 22 millimeters for 6-French. So I had to build the stent to the fenestration and then eventually reinforce that. And we now have a more stable situation. The snare ride was already removed, and we're able to salvage these misaligned fenestration. So that's the case I wanted to share with you today. I think we still have a completion angio, but it's really extreme tortuosity and extreme misalignment of that fenestration. And there are several things we can discuss. I think branches would have been the right choice for this case, particularly the left. I wish I had done a branch, but it's one of those that for some reason I decided to do a fenestration and had to live with that regret. But happy to answer any questions, guys.
Thanks very much. Fantastic rescue. Barend's got a question for you.
Gustavo, thank you very much. It's indeed a great rescue. So if we do a combined fenestrated branched endograft, we would do the fenestrations first and then finish with the branches. And you did this in the other order. Would that have made a difference?
I do that as well, Barend. I usually start with the fenestrations first. But unfortunately, we lost the wire axis on the first attempt. So I move on with the right fenestration and then did the branches and tried to revisit towards the end of the case. But first, the attempt was to do the fenestrations first. And I have to say that more and more we have done this from the total femoral approach to avoid all that tortuosity in the arch. That's the other thing we could discuss. Now, one challenge with this guy was, as you can imagine, I was able to fit a 15-centimeter length tubular component below the renals to put the bifurcated component inside that. So this guy was very tall, you know, and big guy. I had to use a 65-centimeter long brachial sheath to get even close to the. So those things created, no question, an additional challenge that he was just a very tall person.
Gustavo, I have a general question. And it sort of links in with your previous talk as well. As we move forward in the next 5 to 10 years, how do you think we will become better at predicting what happened in this case? So when to use branches, you know, there must be a better way predicting outcome from imaging. Do you think we'll get better at that as the years move on?
I hope so, Bijan. That is where, virtual simulation might help us understand how these stents are going to land or how they're going to behave on this very tortuous anatomy. We can kind of tell on a case like this, it's not going to be easy. You have an infrarenal device, you have tortuosity in the external iliacs, you have tortuosity in the thoracic aorta, you have a renal artery that's coming from the back wall of the aorta. I mean, that is one of those cases when we are in the clinic, we tell ourselves, God, I don't even want to think about the day I have to actually do this procedure, because you know it. And then, so we don't have a good scale of gauging that, how can
exactly.
How can we actually put that in a number? What is the chance of being actually successful, on a case like this?
Maybe we should learn from
well,
a big load of imaging and outcomes.
Yeah.
Gustavo, coming back to that, would this? I reckon this was before the era of steerable sheaths.
No, this was with steerable sheaths, Barend. This was done with, I used the Oscar.
Okay.
But even with the steerable sheath from the groin, I couldn't do it. I couldn't build enough support, and even from the arm, because remember, I was coming from the right, and then here there was this tortuosity, and to turn the sheath, that is very difficult. Sometimes it just wants to point one way.
Yeah. From the arm, no, but I thought from the groin. Yeah. Okay.
Yeah, I did from the groin first, and couldn't do it. And actually, what helped me on that case was the snare ride, because I fixated the sheath towards the vessel, and I could build enough support.
Thanks very much. Thanks both, and thanks to all the speakers in this session. It's been really fascinating, some really good cases. But unfortunately, we're going to have to draw it to a close now in the interest of time and continuing to move on. But thanks especially to our international speakers who've taken the time to join in for this, Gustavo and Barend. Thank you very much. So we're going to have a short break now while we just change everything over for our next session, which is the President's Debate. And even though it's getting a bit late, it's always worth hanging on for that, especially because it's Rachel and Mike again this year. So I expect that'll be a good one. Hopefully we'll see you all again in about 5 minutes.
Yes.